mellitus is a chronic condition resulting from absolute or relative deficiency of insulin resulting in hyperglycemia and other lipid and protein abnormalities. The primary treatment of type 1 diabetes mellitus is insulin replacement therapy, whereas in type 2 diabetes mellitus, when the patient fails to respond to oral hypoglycemic drugs, insulin can be used as treatment. The various available insulin products can be classified as short-acting insulins, long-acting insulins, and insulin combinations. Clinically, the differences among insulin products relate to the onset of action, peak of action, and duration of action. The short-acting insulins include the insulin analogs and regular human insulin, whereas the long-acting insulins include NPH or isophane insulin suspension, insulin glargine, insulin detamers, insulin degludec. And then we have the insulin combinations where the short-acting insulin such as the insulin analogs or regular insulin is combined with isophane insulin suspension or NPH or protamine insulin. So in this lecture I will be focusing my talk on short-acting insulins, which includes the insulin analogs and regular human insulin. The insulin analogs are insulin lispro, aspart and glulysin, and regular insulin is human insulin. To understand the management of diabetes with insulin treatment, it is important to know the physiology of insulin secretion in response to meals and during the fasting period. The figure drawn here shows the natural pattern of insulin secretion from the pancreas in response to meals and during the fasting period. When you eat a meal especially rich in carbohydrate, the glucose gets absorbed from the digestive tract to the bloodstream, and as the blood glucose starts to rise, there is a burst of insulin secretion from the pancreatic beta cells, and this insulin is stored in the pancreatic beta cells, which is released in high concentration in high doses, and this promotes utilization of glucose by the muscle adipose tissue and helps to control the spike in the blood glucose level. So this is the first phase of insulin secretion where the insulin is secreted in high doses and it is stored in the pancreatic beta cells and it helps to lower the glucose surge. Now as digestion continues and more glucose enters into the bloodstream, newly synthesized insulin molecules is released into the circulation, and this helps to stabilize the blood glucose level, helps to maintain the blood glucose level in the normal range and prevent hyperglycemia. So this is the second phase of insulin secretion. In the fasting state, that is in between meals and overnight, there is continuous low level secretion of insulin into the circulation, and this helps to maintain the blood glucose level in the normal range and utilization of glucose by various tissues. So this is known as basal insulin, as the insulin helps to maintain the blood glucose level in a steady state. So the management of diabetes requires a combination of basal insulin and bolus insulin. The bolus insulin reduces the glucose surge, reduces the spike in the blood glucose level after meals, and the basal insulin helps to maintain the blood glucose level in steady state, helps to maintain the blood glucose level in normal range, and this is known as basal insulin. Considering bolus insulin therapy for the management of diabetes, there are two options: the insulin analogs and human regular insulin. So what are the differences and which is preferred for the management of diabetes? The insulin analogs include the insulin lispro, insulin aspart and glulysin. The regular insulin is human insulin. The insulin analogs are modified forms of human insulin, and the structural modifications facilitate faster absorption from the injection site to the bloodstream, so that the onset of action is less than 15 minutes. So the insulin analogs injected at meals, the onset of action is less than 15 minutes. It attains a peak concentration in 1 to 2 hours, and the duration of action is 3 to 6 hours. So this closely matches with the natural pattern of insulin secretion. So the insulin secretion acts as a bolus insulin secretion, high dose of insulin just after meal, and this helps to lower the glucose surge. This helps to reduce the spike in blood glucose level and prevent postprandial hyperglycemia after the meals. Now, since the insulin analogs closely matches with the natural pattern of insulin secretion, there is low risk of late postprandial hypoglycemia. Now, comparing the insulin analogs with regular insulin, which is the human insulin, it forms hexamers which dissociates into monomers and is absorbed into the bloodstream. So, the onset of action takes about half an hour to 60 minutes, and the peak is attained in 2 to 4 hours, and the duration of action is 6 to 10 hours. So the regular insulin, in comparison to the insulin analogs, has a slower absorption rate, has a slower onset of action, and the duration of action is long. Since it has a slower onset of action, it less closely matches with the natural pattern of insulin secretion by the pancreas, and therefore it is less preferred compared to that of insulin analogs, which more closely mimics the physiological insulin secretion. Also, because the regular insulin has a longer duration of action, about 6 to 10 hours, so the action lasts for a longer period and there is more risk of late postprandial hypoglycemia with regular insulin, which is less in case of insulin analogs. So coming to the pharmacokinetic properties. The pharmacokinetic properties of the insulin analogs are designed to be less variable, which means that the rate of absorption and the action profile is more consistent and is more predictable regardless of external factors such as injection site, exercise and dose. Whereas in case of regular insulin, the absorption rate is more variable depending on the injection site, exercise and doses. So looking into the external factors one by one, the injection site influences the rate of absorption due to differences in the blood flow and tissue characteristics. Also, exercise increases the blood flow, enhances the absorption of regular insulin and increases the risk of hypoglycemia. On the other hand, in case of insulin analogs, the rate of absorption and the onset of action is rapid and the action gets completed before exercise-induced variation in absorption significantly affects them. So it is not influenced by exercise and injection site. Also, insulin analogs are designed to ensure that the absorption is consistent across different doses. So the actions of insulin analog is consistent, it is more predictable and it is independent of dose, injection site and exercise, whereas in case of regular insulin there is a variation in absorption and the absorption rate is inconsistent depending on the exercise, injection site and doses. So considering these factors, insulin analogs are preferred over human regular insulin for bolus therapy in the management of diabetes mellitus.